Welcome, everyone. I'm going to introduce my colleague, Claire Fellman. So excited to have her. I'm Shira Daron from Infectious Disease at Tufts Medical Center. Dr. Fellman is an assistant professor in the small animal internal medicine service at Tufts University. She earned her bachelor's degree in biological engineering prior to her veterinary training at Mississippi State University. She then completed residencies in small animal internal medicine and clinical pharmacology at Mississippi State, while doing a PhD investigating the effects of cyclosporin and on immune function in dogs. Following her residencies, Claire began her work at Tufts, where we work together as part of a One Health collaboration with the goal of bringing successful antimicrobial stewardship strategies from human medicine to companion animal veterinary settings. Claire's clinical interests include infectious and immune-mediated diseases. Claire, take it away.
Thank you so much, Shira. And thank you so much for this invitation to present today. It's really exciting to talk about our work and the collaboration that's grown. And so I hope to share some exciting things with you that might spark your interest. So let me get my computer advancing. So first off, we're going to talk about the concept of One Health. I think this is something that is increasingly familiar to people, but it's not just a buzzword. We're actually living this reality and we're seeing improved outcomes as a result of it. And I think as we realize the interconnectedness of ourselves with our environment and with our pets and the animals around us, it's really an important concept for us to start to figure out how we can capitalize on those relationships. And then I recognize that people may not be super familiar with veterinary medicine and veterinary antimicrobial stewardship. And so I'm just going to talk a little bit about how stewardship differs within animal agriculture versus companion animal settings, and talk about some of the work that's being done here as well as internationally in Europe, which Europe is frequently a leader in stewardship efforts. And then next we'll travel to the good old ivory tower. And so I will tell you about what we've been doing at Tufts and some of our research initiatives, as well as some of our clinical initiatives. And then finally, we'll think about what do we do with this information and where do we go from here? So like I was just saying, One Health, probably don't need to explain this too much, but we certainly are recognizing that there is this interconnected nature of our existences, and even things that are not directly attached, we have effects that are going to ripple across the domain spheres. And the goal, as we think about any One Health topic, is really to encourage the healthy people, healthy animals, healthy environment, as it shows on the right. And so, working together, we can really accomplish significant things, and I think there's a lot to be learned from different disciplines. And so I wanted to set the stage for why to care about pets. Why is this something that we're interested in? Why is there research in this focus? And this is an old figure, but it's actually one of the better ones, I feel like, that relays the use rate, relative use by different sectors. And so if you look here, clearly, part of the reason why veterinary focus on antimicrobial use is within agriculture is because livestock consume the most antimicrobials of anybody. So that's a logical thing. But one of the things we know is that we don't touch our livestock outside of, some people do, clearly producers do, but we're not always in very close contact with those individuals or those animals. And so humans have the next biggest slice of the pie, and pets comprise a fairly small part of the pie. But as it shows over here, we know that our pets are in very close contact with us. There's increasing work showing that there's bacterial flora that are shared within households, shared microbiome profiles. And so we know that there's a lot of contact here, and it's even been shown the more contact you have, for example, little kids that are going to get licked in the face by the dog, that are going to be in the dog's water bowl, there's an increased risk that there's going to be carriage and sharing between those parties. Why else do we care? So this is another older figure. So this is data from 2011, but again, it was one of the clearer ones that I could find. And so if we compare antimicrobial use within the two different sectors, so we can see that people, 44% penicillin use, 15% cephalosporins. I'm sure this is familiar to most of you. So we've got a lot of sulfa and quinolone use. Whereas if we look in production medicine, it's really not that similar. So we can see 41%, so a lot of tetracycline use, 30% ionophores. So ionophores are used to control coccidial diseases in growing animals to help support their growth and their health. So that's not really relevant to human medicine. So yes, there's some of the same drugs, but frequently they're different, and definitely the percentages are different. Whereas if we look at dogs, when I've talked to Shira and Kira about this, it's often eerily similar how comparable our DOT data are. And so here we can see this is from a study. They did a point prevalence survey at the University of Minnesota within their teaching hospital, and they repeated it several times and consolidated that data for inpatients and outpatients. We can see penicillins comprise almost 40%. There's a fair bit of cephalosporin use, so 26%, but they also included surgical prophylaxis within that. So I'm guessing that inflated their numbers a touch versus just considering strictly inpatient and outpatient ongoing prescriptions. Nitromidazoles, we're going to come back to this concept. There's a lot of use of metronidazole for acute diarrhea in dogs, and that's actually a really high stewardship priority because it's low-hanging fruit to stop doing it. But that was the next most frequent group, and then we can see quinolones and tetracyclines having very similar percentages as what are used in people. And so, really, not only are we in super close contact with our pets, but our pets are going to be using the same drugs that we do. And so resistance that develops within that animal or resistance that develops within us, both antimicrobial use and disease can affect the other members of the household, and potentially our pets can influence the resistome just like we can. And so this is just a case study looking at this. So we know that there's some sharing of organisms, but I thought this was really a cool one. So this looked at the household transmission of E. coli. They surveyed over a long time, so over 3 years, and they found these 6 different clones that were circulated among different household members. And during that time, both the woman and the dog also had a UTI with one of these. And so, it's just really interesting evidence to support that over a long time span, we're going to see these organisms circulated. And if we have a high resistance pressure due to any member, it can potentially impact that household flora. And so if we think about this, hopefully we're thinking that, okay, maybe it is important, but it's being recognized not just at a local level, but at a national level that we need to be thinking about One Health. And so the 2 reports from PACARB, the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria from June 2021, really had a One Health focus. And so they said, not only do we care about people, we care about food animals, but they actually tied in companion animals as well. And so companion animal medicine is starting to get a seat at the table. It's recognizing the importance, recognizing that we use some really high-powered drugs like linezolid, meropenem, vancomycin. Those drugs are used in animals. And so the first of the reports on the left here, Bridging the Gap, Improving Antimicrobial Access and Use Across One Health. We're going to look at some of the recommendations from that. And then the one on the right, Advancing Interprofessional Education and Practice to Combat Antimicrobial Resistance. So some really collaborative themes within these documents. If we look at what they included for small animal medicine, and so this is, so what they really were focused on within this is trying to report antimicrobial use data. And again, not just within food animals as it shows here, but also companion animals. Because one of the things that's really hindering us as we think about advancing small animal antibiotic stewardship is that we can't track what we're doing. So in some contexts, we're able to do that, but largely we don't have ways to feed in our use. We don't, there's very different electronic medical record systems used. Some people are still using paper record systems. And so there's not a standardized metric system. There's not a standardized reporting system. And so people really don't know, even if they try to do something, whether they're successful or not. And the same is true in production medicine. Some sectors have it a little better figured out than others, but it remains a challenge. And so one of the things PACARB does is, of course, make recommendations that someone has to act upon, but they wanted some funding, and we're still holding our breath for more dollars to be available, but they want to have national incentives to try to get some of this antimicrobial use data. And one of the important points is if we look down here, they want the data collected should include standardized and specific metrics aimed at providing sufficient information for analysis and feedback to encourage the adoption of this sort of reporting. And they want to have uniform collection of data with little effort to prescribers, and so that we can have interoperability of data. And so we're going to come back to this with our Tufts research approach, but they recognize the problem. I think we all know what the problem is, but trying to find a solution that works across the heterogeneous landscape of veterinary medicine remains challenging. If we look at the summary recommendations from the interprofessional education recommendation or report, we can see here that the first things that they wanted to do were share a vision. So they wanted unified definitions and terminology. They wanted to implement this, so having a core AMR curriculum that we can have across dentistry, across medicine, across veterinary medicine, that includes those One Health concepts and includes how we can work together. And along with that, we need to fund it clearly. But if we're going to invest in this and try to tackle this strategy, they have a significant recommendations surrounding monitoring the outcomes to see, does this actually change our AMR profiles? So the terms, one of the things that they highlighted in that is people use these words differently. Sometimes people use interprofessional and One Health interchangeably. Sometimes interprofessional is thought to just include the human medical disciplines. So as it shows here, we've got medicine, working with dentistry, working with pharmacy, working with osteopaths, nurses, public health experts, and that's great, and that's really important. But again, we know the human-animal bond is very strong. We know it has significant implications on health and across a variety of ways. And so I think what they're really encouraging is that we do consider having veterinarians have a seat at the table, that we have this broader thought, and also including environmental experts within that. So this interprofessional collaboration shouldn't just stop at human and veterinary medicine, but clearly there's a lot that goes on in interrelationships. And I think within companion animal medicine, it is so applicable. There's so many similarities between human hospitals and companion animal hospitals, especially the advanced specialty hospitals, that there's a lot of things we can learn and apply. And we've been in this space for quite a while. And so I was really pleased. I've been looking for a better version of this picture because I really like it and I like to put it in talks. But anyhow, pardon the slight granularity, but I have to give a lot of credit to Annie Wayne, who's on the left here. So I came to Tufts in 2016, and Annie was already working on this idea that we can borrow things, we can learn things from human medicine. And so Annie started a collaboration with Shira Daron, my gracious introducer, and Kira Bolak, who was the hospital pharmacist at the time, has since moved to Emerson, but she continues to collaborate with us. And we started working on this problem and thinking about what are the issues, what are the potential solutions. And so we've really sparked a rich collaboration and some rich research initiatives, and we have a lot of work to do. But I know one of the things I just very much appreciate is we have this idea. How do we shape this idea? How do we refine this? What can we apply? What has worked and what hasn't worked? And that's really where we think or where I would suggest some of this collaboration moves forward. So with that background, let's now shift gears into thinking about veterinary medicine. So what is the lay of the land regarding antimicrobial stewardship? So as I was mentioning, and we're going to focus largely on the United States within this conversation, but certainly there's some important work in Europe as well, and we'll talk about some of that. But one of the big things is we recognize majority of antimicrobial use, period, is found within animal agriculture. And there's different types of uses within agriculture, and this gets a lot of attention. And so in 2017, they did a couple important things. So one of those was it used to be that producers could go to a feed mill and they could say, okay, I think I'm dealing with this. I just want to add this over-the-counter antibiotic into my feed ration for the animals. Starting in 2017, that is no longer allowed. And so in 2017, they said that we cannot use all the medically important antimicrobials that are administered in feed have to have the approval of a veterinarian using something called a veterinary feed directive. And so that ensures that the producer is in communication with the veterinarian, they can make recommendations. And the other thing about VFDs, which is what we call them, is that no extra label use is allowed. So they cannot deviate at all in how that is fed, the duration of use. And so there's much stricter bounds on that. And the other thing that came along with this is that they banned the use of antimicrobials for growth promotion or feed efficiency. And so that was use that was just, whether through antibacterial or other effects, it was allowing these animals to get bigger. But we decided, hey, that's maybe not the best use of antibiotics. We need to stop doing that. So what remains within the antimicrobial usage for agriculture? So there's one, treatment of disease, which no one has a problem with that. And we could talk about this for a whole talk. I'm just going to do a little segment on it. But the other one that's more contentious is the idea of prevention and control of disease. And with disease prevention and control, yes, sometimes you're giving antimicrobials to healthy animals, but it's usually in settings where, for example, we're mingling in a feedlot where animals have just come together. We know there's a high incidence of pneumonia. We are closely evaluating those usages and trying to figure out where we can reduce them. I'm not saying it's a bad thing, but just when you hear things about ban all antibiotics when animals aren't sick. Veterinarians are trying to preserve some access to them because in some cases that can actually be a strategy that supports production, supports health, and actually leads to healthier outcomes than just treating them once the point that they're actually sick. So this all came into place in 2017, but there was still about 4% of the antimicrobials that were not under veterinary oversight. So things like penicillin that you can buy at Tractor Supply did not require a prescription. But as of June of this year, those remaining over-the-counter antimicrobials will now all require a prescription. So this was a high priority for the FDA. They've now gotten everybody on board within industry, and those are some major changes. Another thing I wasn't sure if people would be familiar with is within food animal medicine. So veterinary medicine in general, we do something called extra label drug use that I mentioned. Since we treat so many different species, not everything is approved for use in different species. And so extra label drug use allows us to use our judgment to say we can apply this in a different way. But there are a certain set of drugs for various reasons that are not allowed to have extra label use. Not all of those are antimicrobials. For example, clenbuterol, DES are on this list. But some of them are because we don't want any residues. So chloramphenicol, we don't want the risk of aplastic anemia. Some of them are for antimicrobial stewardship properties and reasons. So we can see down here, quinolones have limitations, vancomycin, nitromidazoles, nitrofurans. So there are some groups that do have these restrictions on prescribing. That's not to say we don't use these drugs at all, because there are some approvals. For example, quinolones have a couple drugs that are approved for certain narrow indications, but that's constantly being evaluated. And there was a quinolone that was used in poultry, and that approval was actually withdrawn in response to selection pressure. So they do evaluate this list very frequently. And there's other ones, so there's different requirements for cephalosporins, depending whether you're treating major food animal species or minor food animal species. Sulfonamides were restricted because they had a lot of violations with residues. So this is something that we police. Also, withdrawal periods are required anytime you use a drug in a food animal, an antimicrobial. And so, when the food chain is safe, antimicrobials are not entering the food chain because of withdrawal periods. But again, this is just a little bit of context for you within food animal medicine. So shifting gears into companion animals. So with companion animals, we don't have limits on anything. So we could use any human drug that's approved. And there aren't any restrictions. Now, for the most part, we don't, and we don't have PK data to support dosing. There's some major differences across species, but we do use some drugs. Like I mentioned, we use vancomycin, we use meropenem, occasionally we use linezolid. And so that is something to think about. And we're going to talk about what Europe's doing. So there's not any restrictions in that regard. But veterinarians do recognize the value of stewardship. It's an increasingly frequent topic at CE meetings. There's a lot more general guidelines for how to use antimicrobials, try to avoid them for viral things, try to limit the duration, collect a culture. A lot of it is common sense and fairly basic, but it is targeted at various levels. So we're trying to reach the general practitioners, which do the majority of the prescribing, but then there's also specialty hospitals and veterinary teaching hospitals where some of the higher powered drugs are used. And so there's some recommendations in those groups as well. There's also certain disease guidelines. So we'll talk about the ISCAID guidelines. If you say stewardship in small animals, that's one of the things people are becoming increasingly familiar with. But we have 3 big guidelines that people use. And one of the challenges is we just don't have a lot of evidence to make guidelines. We'll come back to that. But these are some of the groups and some of the efforts. So we can see here the AVMA, the American Veterinary Medical Association, has stewardship definitions, core principles. This is the American Association of Feline Practitioners, and the American Animal Hospital Association also have recommendations. We'll look at the ISCAID guidelines a little bit later. And there's some leaders within the veterinary teaching hospitals as well. So the University of Minnesota I showed some data from their point prevalence surveys. They're now leading a nationwide point prevalence survey of veterinary teaching hospitals as well as private practices. And they have a lot of great consolidated resources on stewardship on their website. And so Minnesota partners closely with their Department of Public Health, and they've done some really good things. So I think, it's not to say that we're blank in this space, but one of the challenges, and I think one of the opportunities for us, is that we're not all on the same page regarding the direction we're trying to go. So I mentioned flashing forward to Europe. And so this is going to be implemented February 9th. So next month, this is coming up really soon, that Europe actually did decide that certain antimicrobials should be designated just for people. And so we can see on these, many of these are drugs we don't use. So for example, cephalosporins with beta-lactamase inhibitors, but we do use some of them. And I've already mentioned, we do use carbapenems, we do use glycopeptides. And not a lot, but we use them sometimes. In some European countries, like in Scandinavia, they haven't been using these drugs for a long time, but they've gone this way throughout the rest of Europe, with the exception of the UK. And it'll be interesting to see what happens to their practice. And maybe it won't make much of a difference, but it does mean if you don't have those drugs, we'll be euthanizing some animals that are unable to be treated with our conventional therapies. They also are ahead of us in another way, that they're working on requiring antimicrobial reporting. And so I've heard from some folks in Europe this may be ambitious, and they may repeal these deadlines or adjust these deadlines as we get closer. But we can see this was back in 2018 that they said within 5 years from 2022, they want data for all food producing animals. And then by 2030, they actually want data from all animals. So antimicrobial use reporting for any animal, whether companion or food animal or research animal. And so that's going to require a lot of infrastructure, but evidently people are gearing up, and this is something that they're working to be able to collect from their systems. And so I think it is important that we have goals, and Europe has set some of those goals. So if we switch back to American stewardship, and where are we? So we are trying to come up with some broad guidelines that hospitals can implement, and the AVMA has done quite a good job. They have a lot of posters that hospitals can use. They have a lot of approachable recommendations, and the 5 core elements, which mirror the human core elements, are to commit to stewardship, advocate for a system of care to prevent common diseases, select and use antimicrobials judiciously, evaluate drug use practices, educate and build expertise. And so these are familiar themes. These are good ideas. And not only are there ideas, they actually have some documents with checkboxes that hospitals can do to try to do or accomplish things under these domains. And Minnesota as well has a handbook that has intermediate or basic, intermediate, and advanced things that you can work on within your stewardship program. Those ISCAID guidelines that I mentioned, these are beloved by many people, and we really like them, and we wish that we had more of them. But one of the big challenges is we don't have a lot of evidence to support these, and so they are very rich in expert opinion. And we're trying to fix that, but there's just not a lot of money for companion animal studies. NIH likes to fund primarily human things. You have to prove a strong translational benefit if you do animal work. But the ones that we do have presently, so this has been revised once, the guideline for management of all bacterial urinary tract infections. So in these few pages, they cover pyelonephritis, catheter-associated UTIs, stones, and uncomplicated cystitis. And then we have another one for skin disease. So pyoderma is very common in dogs. So they've got guideline for superficial bacterial folliculitis. And then down here, we can see respiratory disease. So again, within a less than 20-page document, we're going to cover community-acquired respiratory disease, rhinitis, pneumonia, regular pneumonia, bacterial pneumonia, aspiration pneumonia. We're going to cover pyothorax. And so there's not sometimes as much detail as you might like to see. And again, a lot of this is based on expert opinion. So where are we within our hospital stewardship program? So Tufts, much of what we do is mediated through this ICAST committee, so infection control and antimicrobial stewardship team. And that's one thing that's also a little bit different for us, is that we have to do it all. So we don't have a separate infection control group. We try to tackle these things, as many of these things as we can. Right now, we're having trouble with some CRE in our hospital. And so there's just a lot of things that bubble up that we try to work on. But before we get to the hospital work, I wanted to focus a little bit on what our research collaboration has been doing. And so the first thing that we actually wanted to do, so when Annie and Shira and Kira, when I first joined the team, we were talking about a pilot study we wanted to do to assess the feasibility of trying to look at the effects of antibiotics on household sharing of resistant flora. And so we know that people and their pets share bacteria, but one of the things that hasn't been researched as well is what's the impact of using antimicrobials in pets on the resistance sharing within the household. And so we were interested in that question. We enrolled 8, and we were very pleased to just recently get this published. It was a little while coming, but we had 8 human-dog pairs. And what we did was we sampled them both before the dog received a 2-week course of amoxicillin clavulanate, and then at the end of that period. And we did semi-quantitative selective culture to identify MRSA, to identify VREs, ESBLs, and then we also looked for ampicillin sulbactam and ciprofloxacin resistance. And so again, we wanted to assess what happens in response to this. I will say this study was very challenging to recruit for, so we've changed our strategy subsequently. But we did see some interesting things. And so one of the things we think about is there sharing of flora just at baseline? And there's often a low rate that's shown in studies that have looked at this, frequently less than 15%, often less than 10, and sometimes no shared flora is identified. But even within our small cohort, so we can see the different ones, we didn't identify any MRSA or VRE in this study. But we can see, so there's day 0, day 14. We can see columns for dogs and humans for the different types of resistance. Many of them were not detected, as it shows for the first few pairs. But if we look at day 0 here down for pair H, we can see that they did share a genetically identical isolate. And so in addition to selective culture, we did pulse field gel electrophoresis. And so at baseline, we did have one pair that shared a resistant E. coli. And then one of the things we were really interested in is if we look at pair F and pair G, we can see that there was an E. coli at baseline that was acquired by the dog by the end of the study. And similarly here, we had a ciprofloxacin resistant E. coli that was found in large numbers at the dog at day 14, but was not found originally. And so we suspect this is acquired colonization. And one of the interesting things about this is the pressure of the amoxicillin clavulanates seemed to facilitate transmission from the owner to the pet. We were a little worried that it might be the opposite. But there are a lot of studies that have shown that animals can be reservoirs for resistant infections. And one found a dog with a carbapenem resistant bug, but it turns out the people had been treated with carbapenems. And so, I think when we think about this, maybe the antimicrobial use in the pet may drive some resistance within the household, but we also need to remember that maybe bugs are just going to hang out within these animals and potentially serve as a reservoir to recirculate through the household. So we are working on another study to follow on to this one. Again, with it being so challenging to be able to recruit and get people to stay through the study and bring us 4 poop samples, we're doing more of a cross-sectional approach where we're looking at households without antimicrobial selection pressure compared to households where they did have a beta-lactam or a fluoroquinolone. In addition to the selective culture that we're doing again, we're also doing next generation DNA sequencing, thanks to the support of MyDog, which is a group that runs the test commercially, and they're interested in antimicrobial stewardship. And so we're ongoing with recruitment for this. And I have to do a big call out to Dr. Steinman's lab for helping with these efforts. So the next thing that I'm going to talk about, so that work I think is really interesting, but this I think is really super important and potentially very promising. And so we're quite lucky at Tufts that we work with, that we've got a wonderful CTSI, and Manlik Kwong has an interest and has been tasked with helping with some of these companion animal efforts. And so he has developed a veterinary equivalent of, or an adaptation of, the Observational Medical Outcomes Partnership Common Data Model. And so if you're not familiar with OMOP, which is used in human hospitals, it's a common set of terminology and semantics. So it uses SNOMED, RxNorm, low ink codes, and we're going to apply those so that we can normalize data to compare across record systems. And for us, with this veterinary adaptation, it's going to have some shared human codes such that we can actually do translational work to compare across species. And it is part of a One Health initiative through our COHA unit. So when we first met Manlik, Annie and I actually caught up with him, and he's like, I think stewardship would be a great use case for this OMOP database. And it turns out that it absolutely has been. It's been a wonderful relationship, and I've been so impressed with what we're able to extract from our medical record system to evaluate antimicrobial use. And so just for my visual learners out there, myself included, so this is a look at what we do with OMOP. So regardless of the source data, we can map to these common concepts and these common vocabularies such that we have a homogeneous data output, and then we can compare more easily. And so I think one of the goals is to be able to normalize use across hospitals. We want to be able to look at certain hospital level factors, but to be able to do that, we have to be able to harness the electronic medical record system. So one of the things that we've done as we consider our veterinary use is we want to figure out, how do we classify what are the important drugs? And you guys may be familiar with the World Health Organization has a couple different ways that they look at antimicrobials. And so there's the importance designation, so critically important, highly important, or important. But I think that's a little problematic for us because some of our critically important drugs like amoxicillin are things we use all the time. And so the grouping that we have done more with our work is to the access, watch, and reserve system. So the AWARE classification system. So access being drugs that we want to recommend, watch being ones that we're going to use with caution and try to save if we don't need them, and then reserve being drugs of last resort. We did modify these categories slightly. So for the most part, they're the same as in human medicine, where we've got penicillins, potentiated penicillins, low generation cephalosporins, tetracyclines, et cetera. Watch are things like Zosyn, third generation, and veterinary cephalosporins. There's a couple of unique veterinary cephalosporins that have a little different spectrum than the classic third gens. Macrolides and quinolones. And what we did to make a bit of a veterinary category, because we don't use most of the reserve drugs, thankfully, but again, meropenem and vancomycin are classically watch drugs, but I feel like for us, they're reserve drugs, and so I added those to that category. And so using OMOP, we had a wonderful graduate student that just finished her program, Dr. Emma Price, and she was interested in this One Health, in this translational work. And so using the database, we wanted to look at antimicrobial prescriptions because there's increasing numbers of studies that have reported use for different drugs, but they haven't really looked at things that are associated with prescriptions. So what are the factors driving the antimicrobial use? So initially, we just summarized the use. And so this is 2018 to 2020. See, we had quite a big data set. So over 14,000 dog admissions, over 4,000 cat admissions. And so we wanted to look at, did they get any antimicrobial? And then what were the use rates for those World Health Organization access watch and then our modified reserve group? And so you can see here that dogs have slightly higher antimicrobial, or 10% higher antimicrobial use than cats. And so for all patients, and then within patients, we can see that the majority of antimicrobials, so of the patients prescribed antimicrobials, over 90% were access drugs. That's reassuring. Some patients clearly got both an access and a watch drug. So there were 24 to 34, as we can see, percent that got a watch drug, but only about 13 to 15% of the total amount. And then thankfully, less than 1% are getting our reserve agents. And so this is just useful summary data for us, and I think supporting the relevance of this classification system. But the really exciting thing that we're able to do is we said, okay, we know what's being prescribed. So what's associated with those particular prescriptions? And so we looked at factors that, based on communication among our group, we said we think these things are likely to be associated with antimicrobial use in dogs. They are in people. So we looked at ICU admission, surgery, having a history of surgery within the last 30 days prior to the current visit. Did they get chemo? Were they put on oxygen support? Did they have a urinary catheter? And if you're not familiar with specialty medicine and you're like, do you really give chemo to dogs? Yes, it is a thing. We have many of the same specialties as human medicine. We have ophthalmologists, dermatologists. I'm an internist. We have neurospecialists, cardiologists that do pacemakers. So the companion animal medicine has actually become quite advanced. We're still clearly working on that, but these things are all very relevant for us. And fortunately, so an odds ratio, these show the odds ratios. And you can see that we seem to have picked well in that all of the factors that we thought would be associated were indeed significantly associated with antimicrobial use in dogs. And we wanted to look at the factors that had the strongest association. And so those were surgery and a history of surgery for dogs. And then for cats, ICU admission and surgery were most strongly associated with receiving an antimicrobial. And we also performed this analysis for watch and reserve drugs specifically, but just for time purposes, I didn't include that here. One of the interesting things, if we look at this, is sometimes people will group dogs and cats together, but one of our veterinary sayings is that cats are not small dogs, and definitely there are species differences. And so if we look at the bottom two rows, we'll see that within oxygen therapy and urinary catheterization, both of those are associated with prescription in dogs, whereas for cats, they were actually protective. So there was less antimicrobial prescription if you were in an oxygen cage or if you had a UCath. So why might these differences exist? Well, they just have different diseases. So cats very rarely get bacterial pneumonia, and usually when they need oxygen therapy, it's for congestive heart failure, whereas dogs get pneumonia all the time. And so I think that makes sense. With urinary catheterization, cats very commonly get a sterile cystitis where they block, and then we place a UCath, restore patency, and reduce their stress, and they go home. And whereas dogs that are going to have a UCath usually have some form of terrible kidney disease and they're anuric. And so I think it makes sense, whether from lepto or pyelonephritis, that those cases are going to be on antimicrobials. And so this was validating for us. A, we're finding significant things. B, we're finding that there's some differences within species, and it seems like we have some relevant factors to look at. Another of the things that we wanted to look at was, okay, so we found what the associations are, but ultimately what we really would like to do is say, okay, this is most strongly associated at your hospital. You do a lot of surgery, and so you're going to have a higher level of antibiotic use. And so we wanted to see if we could build a predictive model. the first thing we had to consider was, what model are we going to use? And I again have to credit Dr. Price because I can only relay her data. This is not modeling that I actually did. But what was explained to me is that when we consider prediction models, most of them assume a normal distribution, but we wanted to predict days of therapy, which is DOT. And so we can look at our DOT curve and we see that the majority of patients receive no days of therapy, and then it's definitely a skewed population. And so to address that, we're going to use a zero inflated Poisson that can account for this distribution of data. And the Poisson model has two different parts. So it has a binary part that either says antimicrobial yes, no, or what is the count and what are the actual duration of therapy. And so again, we're not going to spend a ton of time talking about this. These are snapshots of the predictive model performance. And so here we can see the dog model and the cat model. The red line is our prediction line in both figures. And what you can see if you look at the dots, which are the individual patient data points, is there are largely more dots above the line. And so what we found was that we actually did a pretty decent job, all things considered, predicting whether they would get an antimicrobial or not, just using these patient level factors. But we didn't estimate DOT particularly well, so we underestimated that. However, I have to say we are soon to repeat the analysis because another of the things we've been doing is continually refining and validating the data set. And some of those DOTs were actually too high. So I'm curious to see the model performance on our new data. But really what we're trying to do with this is we're trying to establish a way that we can risk adjust. And we hope that these patient level factors will ultimately inform facility level factors. So we can say your hospital has this number of specialists, you have this busy of an ICU caseload, this is what your ICU sees, so that we can know what hospitals should be having. And we'd like to develop the veterinary equivalent of the standardized antimicrobial administration ratio. And so if you're not familiar, what that does is hospitals are going to feed in what their antimicrobial use is. They're going to return their predicted days. And so in this case, the SAR is above 1, which means use is higher than expected. And so they need to figure out why that is. It could be okay, but it's higher than what's predicted, and it identifies areas for improvement. And so this is done across different hospital locations for different types of antimicrobials. We're just looking for a more basic model initially, but we are working on expanding towards this. And just to show you what's being done presently and the type of data that's being reported, this is actually a really excellent paper from 2021 from a really great group. So it comes out data from North Carolina State, from Cornell and Texas A&M. But all they were able to do from pulling from their electronic medical record systems was summarize. And so they grouped inpatients and outpatients, which I think is a little bit of a challenge. Oh, I'm sorry, I meant to mention that the data that I just showed you was all focused on inpatient data. So that was exclusively inpatients, factors associated with hospitalized antimicrobial use. So these were pooled. They did analyze by different groups within the hospital. So they grouped primary care together, emergency and critical care was evaluated separately, and then all the different specialties were lumped together. And so with the boxes, so these are the averages over here on the right. So I tried to do a blue box for you were approximately similar to the average, green is you were better than, red is you were worse than. And so we can see there definitely are differences. So specialty medicine was the most consistent across the hospitals with 20 to a little higher than 20% usage of the visits. We can see primary care was the lowest in general, but that's a pretty big difference to have less than 5% compared to 10 to 12% of your cases getting antimicrobials. And then ECC is where it's really hugely disparate. So we have hospital 2 that has only 12 to 14% prescriptions compared to hospital 3, which has 22, and then hospital 1, which is a big antimicrobial user approaching 40% in dogs. And within the paper, they didn't talk about this a whole lot. They said, well, maybe it's our clinicians' preferences, maybe it's the types of cases that are being referred into different hospitals. And the big question is, who do we benchmark against? They're taking averages, but is that appropriate? And I think we really need to dig down into what are the factors that are driving these prescriptions within these different hospitals. And if we go back to this call from PACARB, so again, they wanted standardized and specific metrics. They wanted to allow easy capturing of data, and they wanted to allow interoperability and a consistent data structure. And so I think, hopefully with what I've said, it's pretty exciting that we have this OMOP tool and also this idea of working towards a VetSAR, working towards applying OMOP to come up with what you should be across different hospital types. I think this is really promising, and we are trying to apply OMOP in different settings. And so Manlick developed it at Tufts, but it's being applied at Colorado State and also at UC Davis. We're trying to get other hospitals, and we're thinking about branching out to networks of private practices that share an electronic medical record system. But there's a lot that goes into applying it. And there's so many different medical records platforms. That's where we've been a little bit limited in our, well, we're working towards it, but it's going to take some time. So to spend a couple minutes looking at what we're doing within our hospital clinically, so I mentioned the ICAST committee. So ICAST is chaired by myself and my partner in crime, Ian, on the right. So since Annie left, Ian's also a criticalist interested in this area. But I think one of the most exciting things, and this was true in our meeting that we just had this morning, is most of the people that come to our meetings are hospital staff. There are technicians, there are ward assistants, and then also some of our house officers come. And they're really interested in infection control and antimicrobial stewardship. We meet monthly and we have a big agenda. So we talk about cleaning, we talk about hand hygiene, antimicrobial use protocols, culture protocols to make sure we're growing as well as we can. You know, all these things fall to our committee and it is a lot of work. I think one of the really sad things to me, or it's definitely an area for growth, is Minnesota that does the point prevalence surveys, and their 2020 survey of the universities, so the veterinary teaching hospitals, they asked how many had a stewardship committee. And as it shows here, 8 of 14, so 57% of veterinary teaching hospitals that were actually able to collect their data in this point prevalence survey, so they had an interest in the area, did not even have a stewardship committee. And so this is, again, where I feel like we need to get on the same page. We need to share some resources. But to be honest, you know, we've only been doing this for a couple of years, what I would consider a formal antimicrobial stewardship program, but we have had our committee in place for longer than that time. We do a lot of different things. We do a newsletter column where we have some educational stuff. I like to tell myself that people read my newsletter column each month. I'm not sure that that's true, but we do what we can. In the area of hand hygiene, this is a really big problem for us. What patients do we need to have wearing gloves? And so we thought about our cases and we talked about, does everyone need gloves? Do certain patients, do all the ICU cases need gloves? And so what we decided to do is when our patients have catheters, they're wrapped with Coflex. Yellow is while they're in hospital, green means go, that the catheter is gone and they can go home with the owner. And we added this pattern vet wrap with the goal to, regardless of where the case is in the hospital, if it's traveling to radiology, to anesthesia, people will know this is a case that we wear gloves. And so we did that for patients with lumens, with ostomy tubes, our ventilator and dialysis cases. If they're known to have an MDR infection, if they eat a raw diet, that's associated with a lot of really nasty bugs, wounds and burns, zoonotic infections, if they're immunocompromised. So it's a fairly logical list. I will admit we are struggling with compliance and we're still working on this one, but I think it's a good idea and we're going to keep after it. We also came up with a hospital guideline. So we summarized those ISCAID guidelines to come up with for our hospital and also including the culture data that we have, recommendations. And so we had first tier recommendations. So for example, for upper respiratories, keep an eye on them, second tier recommendations, and then other considerations. And we made this really pretty poster that we're due to update this year. And we hung it on the wall. And these are my residents feigning interest in their resident made putting said poster on the wall. But in truth, it's actually drawn a lot of attention. So this was when we had first put it up, a big gaggle of students that were oohing and awing. It's funny to me, I see people taking pictures of the poster, and we've also put this on all the Tufts desktop computers. Like, just go to the folder and find it there. But it does seem to get a lot of use. People like having something that gives them some recommendations. One of the recommendations on that poster is, as I've mentioned a couple times, that we're trying to cut down on metronidazole use for acute diarrhea in dogs. We don't really do it as much in cats, but it is just a gut reaction. Dog comes in with diarrhea, gets metro. And again, sometimes people expect that prescription. And so something that our ER told us is, well, if we have something we can give them, that would make our lives easier. And so it's much easier to control diet in animals than it is in people. And so we have 3 days of a highly digestible chicken and rice-based food that's low fat. And so we send home some cans of food. We send home 3 days of a probiotic. We use this for inpatients and outpatients. We have a little feeding guide that goes home, and people love it. We've gotten really great feedback for this. We're talking about having a small bowel and a large bowel pack, but nonetheless, this has been really favorably received. And since our hospital has been talking about it, I've just been super pleased at the responsiveness. And I think this is just an amazing statistic. So I looked at our inpatient metronidazole starts per 1,000 patient visits, and we can see from 2018, where we were doing this quite a bit, down to 2022, there's been a 77% reduction. And it used to be for our inpatients as well. They got diarrhea. Our technicians asked for metronidazole. We've stopped doing it. I have not seen any changes. And in truth, maybe we're seeing, I can't say that we're seeing less diarrhea, but I definitely don't think we've had any worsened outcomes. And that just supports what we've shown on the human side, that frequently these stewardship initiatives improve outcomes or certainly don't worsen them. So I've been very pleased with this. We've also been trying to borrow some other things. So we recognize on the human side that you usually have to put in when it's being filled, what are the reasons for prescribing. And veterinarians don't do a great job of documenting that in their medical records. And so we adapted the indication recording from Tufts Medical Center. We had a veterinarian and a medical student in 2022 that worked on this. And so we just have the body site as well as is the infection documented, suspected, is it prophylactic use, perioperative use, or non-antibiotic, something like intravitreal gentamicin. And another thing that we really wanted to do this for is our ward staff said, we'd be happy to help you know whether the antibiotics are working, but you don't always tell us. And so here it is on every prescription that goes to the wards. Hopefully the prescribers are thinking about it as they put this in. Do I really need this antimicrobial? We've got some work ongoing to see if there are any changes in prescribing in response to this, but improved communication, improved documentation, we think these are all great things. Our committee is also responsible for preparing antibiograms. They're not done for us. So we physically have to input all the culture data into a spreadsheet, and then we prepare our own antibiograms. And we're also working in other areas. So this is a study I have funded through the Morris Animal Foundation. And I mentioned how the guidelines have a limited evidence base. Currently, we have two, unless I've missed one hot off the presses, but two studies that have compared duration of treatment with 3-day durations. And yet in our UTI guideline, they say we can use 3 days, which works in people, of course. But there's one study that compares 3 days of a fluoroquinolone to 14 days of amoxicillin clavulanate. The other one compares 3 days of TMS to 10 days of cephalexin. And no study has evaluated the same drug for different durations of time. It's like, this is a problem. And so the guidelines now say you can use amoxicillin or TMS for 3 to 5 days. Nobody's even said that amoxi for 3 days works. And so this is what this study is. It's a randomized placebo-controlled trial looking at 3 versus 7 days for amoxi for urinary tract infections in dogs. But hopefully that gives you a flavor for how much needs to be done. And there's just not a lot of funding. There are more studies. There's 2 other studies that are working on this exact question. We just happen to all be trying to do it at the same time. There's a couple pneumonia durations of treatment studies. Also in food animals, they're looking at duration of treatment. And so it really just leaves you feeling like there's a lot to be done. So just to close, and I recognize we're getting a little close on time, I want to leave some time for questions. But I know Rima sent this out with with the announcement, but we're very pleased that Nature agreed to publish this for us. So our students that worked on the indication reporting implementation over the summer, it was a medical student and a veterinary student, and it was such a wonderful experience to have them talk, to share ideas, to bring us things, because they spent time with Shira's group, they spent time in our hospital and both of our pharmacies, and it was a very rich collaboration. And so Amy, the medical student, wrote this letter, and so we wrote a communication statement, and in it we talked about how we initiated that, how we have this collaboration, how we're working to apply human strategies. One of the things in there is that pharmacists don't get a lot of training in veterinary stewardship, and so that's an area that needs growth. And the bottom line of our document, we mentioned the PACARB recommendations, and we said to achieve these goals, these groups need to work together to share data surrounding experiences with antimicrobial use, data collections, benchmarking, infection control. And our thought is that this should potentially be housed under somebody like the Society for Healthcare Epidemiology of America or the Infectious Diseases Society of America, that we are going to recruit veterinarians to have their talks at meetings, so that we can have more crosstalk, share more ideas. And there are times, it's not just that humans can benefit animals, but Shira and I have talked about a couple zoonotic infections, and there's a lot of, I think, productive discourse that can happen from closer ties. And so just to show some of the groups that are working in this area, so IAMRI, if you're not familiar, this is a group that's led by veterinarians, but it's the National Institute of AMR Research and Education. And they do a lot of interprofessional educations. They have an interprofessional cohort that I'm part of this year, where they look at some AMR questions and try to build those links and start this conversation. Also the Clinical and Translational Science Award, One Health Alliance. So the COHA schools, that's a big group of veterinary schools that have CTSAs. And those groups are working on things like OMOP implementation. And I think the big questions for us are, how do we organize? Do we go under a human group? Do we make our own specialty? How do we do this at an international level? Should there be legislation? Generally, veterinarians fight against legislation because we do want to preserve use of our drugs, but I do wonder if there are some drugs that should be reserved for human use. And then how can this be supported? I've said a couple times how there's limited funding. And so, veterinary hospitals can work on this, but ultimately we need buy-in from the thousands of general practices that are out there. And so trying to make initiatives that target both of those groups is an ongoing focus. And the other thing for us, as is true in human medicine, is there's different stakeholders in this. And so there's a lot of focus on the prescriber themselves, the one that's making the decision about the drugs that go out, which is certainly important. We also know we need buy-in from our owners. We need our owners to say that, okay, it's fine, we're not doing antibiotics right now. And there are studies saying that veterinarians may overperceive that pressure to prescribe. And so I think people are becoming, as they hear this in various settings that we're using less antibiotics, they're becoming more open to this for their pets as well. We're also looking at how to involve our other stakeholders and our other staff members. So how can we share this message? When they call for a prescription refill, no, you need to see a doctor. When our technicians are talking to them, going ahead and planting that seed that, well, sometimes this is something we wait and see how they do before we start a medication. So with that, that's all I've got for you guys today. I just want to graciously thank my wonderful team, and I'm just a part of this group, and I'm just sharing our work. Ian and Annie that started it all, Shira and Kira that remain engaged, Manlik, without whom none of our data collection and analysis would be possible. Madeline Stein is one of my residents. Katie Marino is our technician that supports many of our efforts in research studies. Emma was our graduate student. And then I think what's been really fun is all the professional students, so both veterinary and now Amy is a M25, that we've been able to enroll or enlist their help in these various efforts. But it's been a lot of fun. There's a lot that we're still doing, but I think it's important, and hopefully now you've got a better feel for the lay of the land when we talk about antibiotic use in animals, and maybe you'll be interested in chatting with us at some point. So with that, I'll take any questions. And happy to field them if you want to unmute or type in the chat. It's all good.
We have a raised hand from Claudette Gardell. Claudette, do you want to unmute?
Actually, that was a clapping hand, but but that's all right, because I sort of do have a question, and that is, okay, so I am a lecturer and I teach a course in antibiotic resistance, and I for first year dental students. And so I always mention stewardship, and I talk about, the prescriptions from the dentistry and how that has not been going down as much as the medical professionals and other professionals. And I try and explain why it's important. And so in the past, I've talked about animal husbandry and as being a main source of why there is so much antibiotic resistance. And so I was pleased to hear from you that they now no longer give antibiotics to promote growth, which I did not know. So they're still just giving antibiotics for prophylaxis and for treatment. Is that right?
That is correct. Yeah, the other uses are banned.
Okay. And so now you mentioned how in June this year, 2023, there will no longer be a whole slew of over-the-counter drugs that are available, but yet they still can have, they can still get the drug by order of a licensed veterinarian, right? So that's how it's going to go.
Correct. Mm-hmm.
Okay. All right. All right. So thank you very much. And so when did they stop the use of antibiotics for growth? When was that? In 2017, did you say?
Yep, that was 2017. And that data I showed, I should try to find a new figure that better collects the relative use on food animals now that they've stopped, because a lot of the tetracycline use was growth promotion. So it'd be interesting to see the breakdown now. But use has declined since that point with the annual reporting.
Thank you very much. That was so helpful, because I'm teaching next Monday. So I really so I'm gonna get my
no, it's interesting. There's a lot of misperceptions, and that thing what I briefly said about people always talk about no antibiotics in their meat. There's never antibiotics in meat because of the control periods and the tolerances that are set. Yeah, so that's an important point that people sometimes don't understand. But and that's just, I know that's not the focus of this, but sometimes people want to say no, they like the no antibiotics ever, but that can actually be a very negative health outcome. And some of the people I've
Yes,
talked to that are
I
producers
understand.
say
Yeah, I
farms
know.
that don't use antibiotics actually have very horrible conditions and a
Right.
lot of animal welfare.
Sometimes you need antibiotics, right? You need, yeah.
Absolutely. So John, our virologist friend, says, Claire, I noticed viruses on your final slide there. Are there any measures of how often antibacterials are misprescribed in vet med? And that is an excellent question and an excellent point. And that's a lot of the focus of the ISCAID guidelines. They talk about asymptomatic bacteriuria, which we now recognize. I know that's not viral, but we're trying to treat that less. Within the respiratory world, we definitely say, try not to treat initially. That respiratory viruses, I think, are some of the biggest times that we are misprescribing antimicrobials. And true, there may be a secondary infection, but that might be something the animal can self-resolve. There's been a couple studies looking at appropriateness of prescribing, but since it often requires manual chart review and we don't have that precise of definitions of what is correct, I'm not aware of real clear data on this point, but hopefully we're improving with the recommendations that have come out. But that is definitely something we have identified, and that's the context where it's most relevant for us.
Thanks, Claire.
Any other questions? Well, thank you guys for your interest. I really appreciate it. And I've got my email there. So if you have any questions or any ideas or any thoughts about collaborating, there are so many things that we can work on, and it's a really big space and a lot needs to be done.
Thank you so much.
I will give everybody another second to type, perhaps.